We had to have a variety of experiences for us to believe more in the people we were with than in ourselves. Our own expertise, somehow. I still have expertise, but I believe more in these problems we're facing. I believe in the local group, the people around are the source of making progress.
The team is coming together again on Tuesday. You will sit in the same chair, have the same conversation, and an hour later, the problem will remain unsolved. Does it sound familiar? Well, when it comes to patient safety, some of the challenges we face are complex beyond imagination. There isn't a simple response, and there are many influencing factors, from the culture, the structures, resources, and external factors. So what can you do to change the outcome? A few years ago, I had the privilege of being introduced to the work of Keith McCandless. He spoke of changing the patterns of how we relate to each other, and that has remained in my mind since. Keith has worked all over the world in a diverse range of fields. From healthcare to NASA, he's helped people and organizations to explore complex problems. If you're interested in hearing how we can influence how we relate to each other, identify patterns within our systems, and encourage creativity in action, then our latest Walk and Talk Improvement podcast is for you. My name is Juanita Guidra, a Programme Manager with the National Quality and Patient Safety in the Health Service Executive in Ireland, and I'm honoured to welcome Keith as our guest and you, our listeners, to this episode. So welcome, Keith. How are you?
Thanks, Juanita. I'm great. Waving from Seattle in the United States.
Hello from Tipperary here in Ireland. So we'll get started. I might get you to tell us a little bit about your work and how you think it's changed how people have connected with each other and solved problems over the years.
Yeah, I guess it started with scientific insights. Oddly, science doesn't often focus on relationships, but complexity science does. So the idea that the pattern of relationships shapes the outcomes, shapes what happens, caught my attention. Early 2000s, started to invest some time in it and translated pretty practical every day for everyone. I'll call them patterns, but typically they're called methods. And those methods have caught on. And they shift the pattern of interaction, shift the relationship. It's very structural. The most interesting thing is you don't have to like to make eye contact. To be good at this, to use these patterns, you just need to understand a little bit about structure. How do you structure interaction? And because those are really quite simple and profound, it seems impossible that they could have a profound influence on the outcomes. But they do. And so what's changed is a lot of people tried them in different domains. I got my start in healthcare and to some degree in safety, infection control, fall prevention, all kinds of things that you know a lot about. But the work has spread across domains and across the world because we identified these patterns that seem to be fundamental. Anybody who's trying to improve or change or make a transition can use them, and they are. So that's what's changed for me personally is many more people got interested in them than I ever imagined and use them. So there aren't concepts. They're very tangible, concrete things you can do.
It's interesting. I had a conversation yesterday with a group of people and we talked about the typical approaches like brainstorming or just an open conversation. And there was an automatic, oh, that'll be a waste of time and there's no point in doing that. But what strikes me about what you're talking about, liberating structures, there is that structure in place. So was that done purposefully to allow sort of us to get to an end goal, or was it just the way you work? Is it just your way of working with Henry?
Well, Henry and I met in this scientific community who wanted to translate the heady ideas of complexity science. And these are things like, oh my gosh, self-organized criticality and the inverse power law and things that would curl your hair. But we were able, through a consulting practice, to go and be a guide on the side or a coach or a consultant to people and organizations trying to adapt creatively and being frustrated with things like brainstorming. It seemed disconnected to the local situation. And so the theory was very compelling, very interesting, almost too fascinating, because it wasn't clear how it would be applied to, let's say, infection control. And so there were 10 years of field work trying things. And they tended to be very far from brainstorming, very far from presentations, things like status reports, or even facilitated conversations. So what we found is there was a way to find the absolute minimum structure needed to get somewhere to generate action and get a result that was positive. And that minimum structure turns out to make all of the methods or the techniques quite simple to learn, but they're kind of required. They're the minimum must-have things, but they are, just to demystify it, they're things like, well, you start talking. First, you think for yourself, then you talk with one other person for a couple minutes, and then a group of four, and you're looking for similarities and differences. And it's that kind of thing, like every voice is included. So we were translating scientific concepts about the dynamics of complex adaptive systems. And the most interesting thing was we were studying termites and sand piles and the stock market and everything, working with mathematicians and physicists and biological systems sometimes, but they'd be at the microbiological level, not managing or organizing a group of people. So those was interesting that the patterns were kind of universal. The way that complex systems organize themselves just needed to be translated to what are we doing in this clinic, in this hospital, in this particular setting. And we were able to come up with a draft of 33 things that are extremely helpful for people.
And I think what I love about it is they're accessible. So you've just spoken about the complexity and on a whole host of topics that for a lot of people they might never come across, but these liberating structures are really accessible. So anybody can go and use them within, say, a healthcare setting where we are talking about those complex problems. So if I was to bring you back to that example you gave of a superbug, we talk about infection control all the time and the impact within a healthcare system can be extreme. If you were to take me sort of to that example, people coming into that meeting on a weekly basis for their update on infection control, how would you introduce liberating structures there? How would you start to change their conversation?
Well, I've done that a lot. So I'm going to give you a direct example.
Brilliant.
Well, I wouldn't have the meeting, first of all. We'd take one of the structures, and I think it would probably be discovery and action dialogue. So there's two words there, discovery. We're going to get everybody excited about discovering something that they didn't see before, which is immediately engaging, but we're leaning into action. So we're going to do things with this. It's not up in our head.
Yeah.
So we're going to do that, and here's how it works. And I'm going to coach somebody in the group. We're going to go on to a unit, first of all. We're going to go where the work is. This doesn't happen in a meeting room.
Good.
It does a little, but let's go to the unit. Let's go wherever the action is. We're going to ask a series of questions, and I don't need practice with this technique, but you do. So I'm guiding somebody in that group, or multiple people are going to separate units and having this experience without a guide on the side because it's pretty simple to do. And there's 7 questions. You ask them in order. So the first one, if I'm with somebody, I'm close enough to them to be able to say, don't do that or do this, because typically they'll over control or under control the conversation. So the first question, you need to say why you're there. Why are you visiting the unit? It's kind of odd for somebody from the outside to visit the unit and they don't really want you. So you need to have a strong purpose or something intriguing. So, we're here to stop the spread of superbugs to your colleagues and to patients on this unit. What? What? Then we'd go on to a unit and the manager would tell us, oh, everybody's way too busy. This is mostly hospitals, but it was other places too. No, nobody will come over and talk to you. Well, that was completely wrong. A lot of people came over. Sometimes we'd vary that first question. How can we be sure that every patient and every staff member on this unit pick up a superbug today, just to get attention? And people had good answers. Well, let's not clean. This was mostly just methicillin-resistant Staph aureus, MRSA, but it could be anything. Well, we don't clean the surfaces. We don't pay attention to the isolation sign on the room. We're just going to go in and we're not going to touch anything, which are all fabrications, turns out. But we go onto the unit, we ask the first question once we're clear what we're doing there, which just the visit in and of itself is kind of interesting. Oh, you respect us enough to come to our unit.
Okay.
This isn't a message from on high. No, you're there.
Yeah. Yeah.
So how do you know when the superbug is present? Well, and there's some people who clean rooms there, and there's some doctors and nurses and various people are there. They're ready to talk, and they all have a different answer.
Okay.
Second question is well, what do you do to prevent the transmission? What do you encourage others to do? Again, lots of answers, and they're all hearing each other's answers, and they're tilting their head a little to the side. Like, oh, I didn't know that's how you clean that I didn't know when you transport a patient, all of the things that different people knew in their role, but there wasn't nearly enough. It was just little things, kind of, the first blush of it. Third question, why is that hard to do that all the time? It is really hard to prevent superbug transmissions. Just the isolation, the cleaning your hands. You don't even realize, if you're in healthcare, it's hard. So, fourth question, and it's really cooking at that point. It's kind of mysterious, and we're looking, well, do you know anybody who seems to effortlessly or artfully just do this routinely, prevent the spread? What do they do? Do you know what they do? One of the times I was with a group of hospitalists. I don't know if in Ireland whether you have them, but they're internal medicine. They're the gurus in the hospital. They're the most powerful. And we're having this conversation, and we got to just the second question. It was what do you do to protect yourself and others? And one of the top guys, of course, they were guys, said, well, I round my superbug positive patients at the very end of my day.
Oh, that makes sense.
Right? It does. And there were 9 other physicians there. They didn't say, oh, that's cool or anything. Their heads just flipped over and looked at him for a nanosecond. And in that moment, they all changed their behavior. Just like you, they said, oh, that makes sense. I can do that. I won't be taking superbug from one patient to the next if I do it at the end, and I'm conscious of whatever that may be. And that's the way people learn. You hear things, but you're also in those questions. If somebody's doing it routinely and effortlessly, how do they do it? You've started a process of discovery. And if you're coaching or leading or whatever your role is in making change possible, that's what you have to have, an ongoing discovery process that's simple to repeat. So these folks who weren't in the meeting room have now had this conversation where some really interesting things came up, and they've sparked curiosity about on this unit, and you have a start.
And the action piece of it, does it always come from sort of a behavior that somebody's doing, that sort of positive deviance where someone is making it work and we take those ideas away? Or do we move into sort of an action? What are we going to do collectively?
Well, this is where the complexity theory comes in a little bit. They're using their discretion and immediate ability to take action. So those doctors, when their head snapped, when they snapped to attention, I think their behavior changed.
Okay.
And I've got tons of stories like that. So what am I going to do that's different? And typically you get on the unit, some of the first things that started to happen in this discovery process. Well, let's put a hand cleaning dispenser gel where I need it. Let's get the right size PPE.
Yeah.
Right. And let's learn how to take it off in a way that doesn't spread surface superbugs. And so we found people and videotaped them. Sometimes in the moment, people would learn a lot, but also when we'd find an artist who was good at taking off the PPE, it was like an improv actor. Suddenly we had a video of somebody who knew how to do it and do it with style. So yeah, the discovery process is the main thing. You have to go to that unit or go to the place where the action is, spark curiosity, be clear about why you've come. Like, what's the purpose of this?
Does it have to always be somebody from outside?
No.
The prophet in their own land. This is the question.
Well, these big problems we have, big challenges, you've got to start somewhere. So our strategy was always get it going in one unit, give them a lot of support. And then the other people around them in other units, oftentimes it was the managers like, oh, your numbers look really good. What are you doing over there? And of course, they hear things and they see that strange people, like I have no business going into ICU or other places, but I was there with somebody who was in a role outside of that unit. So it was kind of odd to have them there. But what we were really doing, we're looking for the people who their eyes got big when we did what we did. The discovery and action dialogue questions are real straightforward. So somebody on that unit can take it from there.
And can I ask you, what struck me when you were talking about doing something on the unit, would you ever bring the patient into the conversation or a few of the patients into the conversation if they're well enough?
We were within earshot of patients often, and they were curious about what was going on. I don't think I was in the room when that happened. I was in the room. I'm doing another project. Also, that involved discovery and action dialogue on training young physicians to attend to the spiritual needs of patients after a difficult or devastating diagnosis. And I didn't want to be in the room, but I was for a conversation, for a dialogue about that. And yeah, so you definitely can. With patients, a typical thing would be a more playful way to go after it is how could you be sure to transmit the superbug to others around you. What's your role in spreading it? And you do it with a smile and a wink, like so that they also get that they have a role in not spreading the superbug. I don't think as an external consultant, that wasn't my role. I think it's smart not to include me in those conversations, but they need to have them internally before you could have them be comfortable with a conversation like that with a patient, I think.
And tell me this, you talked a little bit about being clear on the question to start with. How much time should you put into sort of identifying what's your key question or what's the hook if you're doing some of this work?
Well, we had a multi-site across the United States and Canada project, and the first site I was the coach.
Okay.
And so with this nurse, Nancy Iverson, she's the infection perfectionist is what we called them. Everybody called them that because they wanted perfection always. We went through 3 versions of that.
Okay.
It's a purpose, trying to describe the purpose of the work, and it gets turned into an invitation to people to work on that purpose. So the first one was something like, how can you improve your behavior? How can you stop the unsafe behaviors? Nobody wanted to talk about that.
Not very appealing.
Already been punished or warned or incentivized to change that. So that was a loser, but we tried it for a while. Second one was, well, these are patient safety goals that we hold dear. Well, it turns out everybody didn't hold them that dear.
The day-to-day, it's not as immediate.
But it's not like, okay, this is where I live and work. It's my area, my unit. I have some authorship or some power over whether people have we spread this to each other and to patients where I live, where I work, right here. And I'm being invited to do something about that. Now that seemed to make a difference. So that took months to get to something that could spread across this health system. We were trying it as we went to different groups in the hospital, getting the statement right. And it's got to make sense and be compelling to a pretty diverse array of people. Because our goal, and for superbugs and lots of things we're working on, patient safety, once you look at it closely, nearly everyone has to be included in making some changes to make real progress on the problem.
And it seems to translate it from that sort of aspirational patient safety goal into something that's going to affect me directly and the people around me. And I think for me, when you talked about that hook, when you go into the actual service, that made a huge difference in terms of how I might engage in something because it's much more personal, because it does affect me. That's really powerful.
I've heard you say the Irish health system is making more of a transition into home or into local. So that's easily translatable to you show up at somebody's home. What can you do to protect, restore?
There's a patient partner that I've worked with and she's phenomenal. We talk about integrated care and a lot of our conversations were around where does the care journey start? And for a lot of people on the chart, it was within the community. It's your GP. And she said, no, she said, stop. For me, most of my care is provided in my home. Christina's phenomenal. She talks very much about it starts there. And she's right. And a lot of our day-to-day healthcare needs are looked after in the home, whether it's with an intervention from somebody externally or it's just our own minding of ourselves. So there's something about that. One of the things that strikes me, and you talked a little bit about having that diverse group part of the conversation. And in healthcare, we have a lot of hierarchy. Some of that's necessary from a decision-making clinical perspective. The governance side of it needs to be really clear. But when you're trying to do work like this, where you want to change the conversation, it could be really challenging. So the question I have for you there is, how do you think that power or that control can influence our capacity to work as a team? And how do we change it?
Yeah. Well, most people, particularly if you've increasing levels of authority, formal authority, you probably got there by doing things by yourself. You had a strong internal drive, and I've worked with lots of leaders, and when they get excited about liberating structures, they'll say something like, well, I thought I had to do it all myself. I thought really I was the one that I could rely on myself, and I needed to do that. And as you rise in this position, you try a variety of times kind of participative things. They don't work that well. Generally, you don't engage enough exchange of perspectives and depth in the responses, and you don't sustain it long enough to really get something that blows your socks off. That like, oh. So when we were doing this work on units and various things, I would always ask the CEO to show up at something.
Okay. Visibility.
Well, it's just, I also had experiences where a couple of units had made incredible progress. And then some of the people at a hierarchical level above had heard about it, but they weren't there. And they were kind of, upset. They were like, how can you improve something without my guidance? I was like, I laughed out loud inside. But I get it that most people have not had the experience of a wise crowd. They've not seen the results. And the reason we're attracted to the hierarchy is because it's predictable. It may not be brilliant, but it stabilizes. So what I always try to do is get the most senior leaders who are willing to be the one to go and try the discovery and action dialogue, or invite 15% solutions, which is, invite people to do what they have the freedom and discretion to do to solve the problem right now. And if you hear it from somebody is up in the hierarchy, it's like, oh, that feels like respect. They believe in me more than anyone has before, and maybe more than I believe in myself even. My experience so far has been that lots of senior leaders need that direct experience of the group wildly outperforming the expert, the individual that you put in charge. Takes a little cultivation, takes a little time, coaching. I call it guiding on the side. The leaders just need to feel it, the tangible part of it, and including them from the beginning, at least inviting them continuously into the work.
Yeah. So sometimes we've seen when we're working with groups, the senior leader comes in and the conversation is very much directed towards what people think the leader wants to hear. How do you stop that from happening?
The most fundamental liberating structure that I know you use is the 1, 2, 4, all. So first you think for yourself. And in that moment, you're very brave. I want to say the thing that I believe, I'm not editing it. Then you're with one other person and you might share some of that bolder, bigger, harder idea. And then you're with a group of 4. You start to get a picture of, wow, we haven't solved this problem. We're still here. And then out of the group of 4, you invite that group of 4. And CEO has done the 1, 2, 4, and they're somewhere in the group. And then you invite the group of 4. Is there anything that came up in your group that's so powerful that everyone else should hear it? It's so important, so bold, so goes to the heart of things. And just one, and the person who reports it isn't associated with it directly.
Yes. Yeah. Okay.
And that is pretty easy to do out of our group. So the way I just phrase that is like, tell us something that happened in your group, an idea or a suggestion or a challenge that's so powerful.
To share.
Came out of your group. Everybody should hear it. And it's not this long list of stuff, everything that happened in the group, and you repeat everything that every other group did. It's not that. I'm saying CEO, but whoever it is, they might think, oh man, we solved that problem so long ago, but there it is again. Or it could be a completely different take on it. So then you've got to, okay, let's do something about that. Did that answer your question, Juanita?
It does. It comes back sometimes to that psychological safety and creating that trust in the space. And sometimes it is about having an opportunity to really have the conversation where you don't feel I'm going to be exposed. And I think 1, 2, 4 all really helps with that. You'd mentioned wise crowds as well, and that's one of my favorite. I just, of all the liberating structures, I love wise crowds. Do you want to tell us a little bit about that?
Well, I like its little cousin, Troika Consulting, even more.
Yes, yeah.
It's very similar. I want to describe that just the teeniest bit. So each person has a chance to ask for help on something that matters to them, and usually don't specify anything about what that might be. But if you're in a work group or in your setting, it's probably going to be about work.
Oh, that makes sense.
And one person's going to go first, and they're going to ask in a sentence or two what they want help with. And really, there's just a minute to describe it, whatever it may be. Then there's 2 people facing you that ask a clarifying question or 2 for a couple minutes. They can't nearly get enough information, but they've heard you, they're looking at you, they hear what you're saying. And then if you're the one asking for help, you turn your back on the 2 others. And this can work online or face-to-face. You turn your back on them, and they're invited to go wild, do everything within their power, including changing the frame of your question to help.
Okay.
And they act as if you've turned your back on them, like you're not there. They know you're listening, but the 2 consultants are invited to do everything in their power to help. They have 3 or 4 minutes. This is very brief. So they have to use their intuition, their imagination, whatever they picked up, nonverbal and verbal from this question and the way it was asked and the demeanor of the person. They're doing it. They're helping. 3 or 4 minutes, this thing goes on. The person turns back, faces them, and says, thank you. And if they're capable of saying, what happened that was helpful, they can. But oftentimes they're completely overwhelmed because for a few minutes, 2 other people had their back. They were there for me completely.
Yeah. Yeah.
And then the next person goes. The important part here too is it's not just that one person was vulnerable and asked for help. The next person is a little more vulnerable and asks for a deeper level of help and gets better. You improve. This is peer-to-peer coaching. And then the next person gets better at asking their question, and the others get better at giving a response, and they all get better at accepting help, which is really hard to do. The way our culture works, and Ireland might be like this. I just think it is probably really not a good idea to ask for help most of the time. That's the essence of wise crowds as well. These people around you are wise if you ask.
Yeah.
If there's a structure to get the help, and that little structure there, here's 2 people, it's very short, you turn your back, there's a physical part to it, and that is the minimum required, and you gotta do it. Don't mess around with that. At least when you get started, don't mess around with it. It's the minimum required to get fabulous, imaginative help
Yeah.
for people in your group.
I think what I love about it is, there's sometimes a perception that, you need to have a full day blocked out so that you can look at a problem or a challenge, or that you need hours put to the side. And this is short and sharp and really quick. There is a vulnerability in it, asking for help. Very few people I've met that say, "Oh, I love asking for help. It's great." That I have to excuse myself like that. But actually, there's a great privilege in hearing from somebody else their thoughts and ideas. And I wondered at the very start, the first time I'd seen this done, why would you bother turning your back? Could you not just look and listen and hear more intently? But actually, what I found was your facial expressions. My mother says I can't hide anything on my face. It says exactly what I'm thinking. And it stops people sometimes from maybe engaging fully or saying something. They might start a conversation and you give them a look to say, "Oh, we already tried that. We did that already." And they stop before they can finish it, and it doesn't evolve into anything else. I think that actually is one of the most amazing things about it. It has a different type of conversation.
I know that every boss I've ever had, the slightest movement of their eyebrow would tell me whether I should go forward or not.
That's it. You don't need to do anything else. You made a decision. You can see it. One of the things that sort of brings me to mind is that it can be hard, when you're working with people and you have an ongoing relationship with them, to talk about things where it might lead to conflict or it might lead to a difference of opinion. Are there ways that we can create conditions where people feel safe to challenge the status quo? And I know you'd mentioned 1, 2, 4 all, but are there other things that help in that space?
One thing for the people in the hierarchy that are higher up, there's usually a group around them that are functional leaders. And so there's a liberating structure called What I Need From You. And they're responsible for the operation of their function. And so they want to optimize that. That's the way a machine works. You optimize each function. Well, people are not machines. Duh. Over time, it's kind of the leader's role to coordinate or get these folks who are trying to optimize these separate things to work together. When that gets entangled beyond what's comfortable, there's tons of conflict and a history that just goes on, and disappointment and despair over the situation. And so this What I Need From You is good for that. And so each functional leader has a chance to ask each of the others for, this is what I need from you to reach this goal that we have together. Let's say it's patient safety or whatever, financial or whatever it may be. Here's what I need from you. And those are heard, and the leader goes back to their functional group and formulates a response. But there's only 4 things. So the structure here forces them to say one of 4 things back to the other functional leaders. And this includes the administrative leaders too, or whatever. So it's yes, which means, yeah, you're going to get that from me.
Support it?
No, never. Go somewhere else. Your request is so vague, don't have any idea what you're talking about. And it's a challenge, but it happens a lot when there's been misunderstanding over a period of time. And then the last one is very cathartic. It's whatever. It's like when a teenager says whatever to you, what does that mean, Juanita? You don't have teenagers yet.
No, give me 2 more years.
Well, okay, you're new to it, but a whatever means you totally don't know
Okay.
who I am or what I'm doing.
Okay.
So it's a little disrespectful, but it also tells you don't know what the people in that other function are doing. So, for example, I was at a big clinic in the United States, and they were doing on patient flow through a thing. And the people at the front, as patients walk in, it's a big deal. They know a whole lot about stuff. And they asked the doctors, we want to know more about discharge and all that works. And the doctors wanted the front staff to just respond to any whim anything that they requested in the moment. There was nothing they could say about what they really needed because they didn't know anything about the function of welcoming patients into the clinic. They really didn't know. And so the position they had made them blind to the functioning of the larger unit. And it became incredibly clear. The physician who was representing all the physicians as their leader and the person from the front desk, they kind of had a good relationship and they laughed, but it revealed one of the main problems with patient flow through is the front desk and the doctors didn't understand what each other did. Particularly, the doctors didn't understand the front desk. So I think you were asking me when there's real challenges and disagreements, like how do you address that? So this back and forth, you generate a set of agreements and places where you've got to work on it.
Okay. Okay. So at least you can have an honest conversation around it then and check in and see where you're at.
I often say it's a religious it's a religious event of some sort because it's very dramatic
Okay.
and it feels like at any time a bolt of lightning can.
And come down.
It's also playful because of those yes, no, whatever responses. It clears away all that cluttering obfuscation that is typical between professionals.
Okay. What came to my mind there as you were talking about seeing the staff and not knowing what other people do about simple ethnography. It's another one that I really like. If you might just tell us a little bit about that.
I was at a hospital and we were doing the superbug work again. And it really bugged me that they were blaming a particular patient for spreading superbug around the unit. They were blaming this patient, and these were the infection control, the manager, somebody vice president in charge of something. And I said, I want you to just go and sit around the door different times, but take 20 minutes out of your busy schedule and just do the simplest ethnography possible. Look for what people do as they walk by, who goes in and out, what is the patient doing in the room, and just describe it as factual observations about what's happening. And so they came back, I think 4 of them went out and did that, and they understood immediately what the challenge was for this patient. They were pacing back and forth in the room. They charged for TV, so the patient had nothing in the room to keep them in the room, and this was a precautions room. So most people, as they walked by, they'd go really wide away from the room. Everybody almost avoided. So this was a kind of like what they got to once they collected all their observations is we have isolated this patient. We haven't helped this patient safely move anywhere. And we can do that. There's a lot of solutions for that. And we don't need to blame them for spreading things. It was really, we didn't understand the conditions of what it's like to be in a precautions room. And I was like, okay, that's the best thing. And then we'd also do that thing for moving a patient from one area of a hospital to another. You know, how do you get somebody down to an MRI?
Yeah.
Let's look and see what happens along the way. And it's pretty easy to do. It's pretty fast. And you can quickly see where you're not doing a good job.
It is fascinating. We did a training program at one stage and we sent people over to Houston Station for half an hour to observe to see what that they could see. And they came back and they said that in the middle of the station, you can go get your train ticket, pay for your ticket. And there was always a continuous line. What they didn't realize was that if you went around the corner, there was another ticket station at the back of it and nobody knew because, they would always just routinely stand behind the line. And it's small things like that. Somebody observing for 20 minutes or so can see just something really powerful that can change how you work. I love that idea. I love that idea about just observing and making changes on that basis. For people that haven't done this but are interested in maybe starting, what conditions are important to use liberating structures? Like, what do you need if you want to try these? What's important in the culture? What's important in the environment? Or can anybody do them anytime?
Anybody can do them anytime. But the pattern, there's usually somebody that goes first.
Okay.
And there are people a lot like you. Oh, what are you like? They're curious and they really have ambition to make a difference. Their curiosity overwhelms their fear of being different. And you can use these things we've just talked about in an imperfect way and still get results. But the thing to do, and it depends on your position, how brave you're feeling that day, because you're kind of changing the rules of interaction. You're saying each person take a minute and think and write something down. Suddenly that's different.
Yeah.
You have to have the courage to try that. And then you're just going to talk to one other person. We're not going to have this thing where we all sit back and see what happens. What kind of crazy stuff's going to happen today? And so you're taking a little bit of leadership. You have to believe before you see the results.
Well,
That's really the only precondition. It does help to be really frustrated with the result. For me, I had tried everything, run through continuous improvement, and then got into benchmarking and idealized design and systems thinking and simulation. And I ripped through everything that you could imagine that was change oriented and was getting lackluster results. So it helped me to be not only curious, but very frustrated with my own results.
okay.
So that might help you. And it's okay to make yourself more frustrated as long as you stay hopeful.
But how do you stay hopeful? You've been in this space for a long time. How do you keep that hope and that curiosity alive when it can be hard and it can be challenging?
Well, we eliminated the transmission of superbugs at a bunch of hospitals, a bunch of units, and they sustained it for a while. So I'm maintaining hope now. You can see it in individuals. I can always see they're fast and quick and imaginative, and they can spread it. So I can see that it's spreading. I want to see the diffusion of the work. This work, there's no central office, there's no course you can take, but it's spread all over the world. So what gives me hope is something that like this that works pretty well and connects people and helps solve big, gnarly, impossible, complex problems can spread. Now, we made it free. We did all kinds of things that make it easy to go get it and use it. So that gives me hope that it's spread around the planet without any of the commercial nonsense that usually is attached to change methodologies.
Yeah. That brings me then to one of my last questions. It's that piece about the people listening. A lot of them are leaders. They're working with groups. They're aspiring leaders. Some of them are coaching. Some of them are in quality and patient safety. What advice or guidance would you give them?
Start trying a couple things. You can't go wrong. Your experience, I think sharing your experience, it sounds like Wise Crowds and 1, 2, 4 All and maybe Triz or
Triz is fabulous. Yeah, I love Triz.
yeah, Discovery and Action Dialogue is a little bit harder. But just try it at a super small scale and see how it goes for you and find a partner. Like Henry and I, my co-author, we had to change our own behavior before we could do some things. We had to have a variety of experiences for us to believe more in the people we were with than in ourselves. Our own expertise, somehow. I still have expertise, but I believe more in these problems we're facing. I believe in the local group, the people around are the source of making progress. And so trying some things where that can be revealed to you and you believe that it's working, and then keep going, build a repertoire. And I've seen people go through the 33 that we first developed and probably another 50 out there. But once you get the feel for it, the next one isn't any big deal. You develop truly not just a practice, but a repertoire.
And if you were signposting resources to people who are getting started or who want to expand that repertoire, what would you be suggesting to them?
Well, there's a website, an app. I know you like the app.
Yeah.
It's very simplified. The website has more
Context.
There's the first book in a year into a second book, which features more online and some new structures. So all those things are accessible. And then in the healthcare domain, there's lots of great people out there. The other thing that exists, I know there's a couple user groups that feature liberating structures. You know them better than I do, but they're there. And then some real maestros, including you in that, so people can rely on you and others. Well, some of your colleagues are highly skilled. Find some resources, but find that person who'll partner with you, who'll be your guide on the side as you do the work. They don't have to know more than you. They just need to know you well enough to tell you, maybe stop that and try this. That's really helpful.
For me, there's a few others here that have used them for a long time. And, sense checking with somebody else, or I think testing something out with 1 or 2 people, actually, for me, was probably the best learning. I like to learn by doing. And even say the first time I did impromptu networking, I think we were short a person. So I joined in with the group and then realized I couldn't get myself out of a conversation to get back to the calling everybody back. So it's a really simple thing, but I would never have known that if I hadn't tried it. the Q community have a user group, and it's a fabulous opportunity for people to join in and to experience with a group if you want to learn with others, or you don't have that many people around you that you can work with. My starting was the book. I ordered that book because I'm a real dog-eared, and there's, post-it notes stuck on ones that I like, but I like the app when I'm in the room, just to sort of give me a quick reminder if I need to check in to see what we good in this space. It's helpful. Do you have any final thoughts or takeaways that you'd like to leave the listeners with?
Just healthcare is incredibly complex. So there's quite an array of opportunities, both in the clinical. All the chronic disease is a place where I learned a lot from people treating chronic disease about what structure helps somebody be at the best health. So yeah, I think that's the main thing. Is I know healthcare is a little harder than it used to be, but this could really make it easier. You can rely on more people to do the work and support people's health. So
Yeah.
yeah.
And I know as we come to the end, I just want to thank you, Keith, for sharing your wisdom and your experience so willingly. I know every single time I talk to you, every single time without fail, I learn something new, and there's always more to be learned.
Good. Thanks for the interview. I appreciate the chance to talk with you.
For the listeners as well, we hope that Keith's insights will continue to inspire you in your work to improve health and social care services. At the moment in Ireland in particular, there's a lot happening with integrated care, and these structures provide a fabulous way of working together and collaborating. So it's definitely worth taking a look at the resources. We hope you enjoyed the episode, and if you want to hear more content like this, you can listen to Walk and Talk Improvement wherever you get your podcasts. Thank you for listening.